broadly speaking, what I want to say is what we call targeted therapy, and I'm going to come to this a bit later on. Targeted therapy generally, as of today, and things are evolving, as of today, generally is not an option in small cell lung cancer. So I'm going to sort of now go into how we approach small cell lung cancer. So broadly speaking, as everybody knows, there are four stages of lung cancer, both in non-small cell and small cell lung cancer. But when it comes to small cell lung cancer, we broadly look at whether it's limited stage, that is limited to the lung, may have spread to the lymph nodes, or is it extensive stage, which is already spread to other sites of the body, such as liver, bone, or any other site. So if it is limited stage, in those patients, we tend to do chemotherapy and radiation. If it is extensive stage where it has already spread to other areas, we tend to do chemoimmunotherapy. Broadly speaking, the new small cell lung cancer patients are diagnosed. About a third of the patients have what we call limited stage patients, and 2/3 have extensive stage, whereas that proportion may be somewhat different in non-small cell lung cancer, where almost 50 to 60% of the patients would have what we call limited stage. We don't say the word limited stage, we say stage 1 to stage 3, whereas about 40% in non-small cell lung cancer patients at diagnosis have what we call stage 4 disease. Now, one important thing to remember is in small cell lung cancer, whether the patient has limited stage disease or extensive stage disease, we are going to treat these patients with chemotherapy. And why is that? Even when we see the patient has limited stage disease, limited to the lung or has spread to the lymph nodes, we know based on our study of lung cancer that it has already spread to other parts of the body. It's just that wherever else it is not yet big enough to be seen on the scans. And so it is never going to be enough when it comes to small cell lung cancer, where we only treat what we see on the scans. We need to be sure that we are giving a treatment that goes everywhere. So chemotherapy, so in small cell lung cancer, however small the main mass is, the main tumor is, and even if we did not see evidence of lymph node metastases, we assume the cancer has spread somewhere else. And therefore, we need to give treatment that goes everywhere. And when it comes to small cell lung cancer, as of now, the treatment that goes everywhere is chemotherapy. And so chemotherapy is going to be part of the treatment whatever the stage of small cell lung cancer is. Then if it is limited stage, we sometimes do surgery, but most commonly, if it is limited stage, we do radiation, whereas in extensive stage, we do chemotherapy and immunotherapy, where we rely, because we are trying to deal with entire cancer. It doesn't help to just radiate one area. You need to deal with the entire cancer. So once you can see the cancer at other places, we essentially rely on chemotherapy. So what really changed over the last 4 or 5 years? Prior to that, for 30 years, the only thing we did was chemotherapy as far as treatment that goes everywhere when it comes to small cell lung cancer. What changed about 5 years ago is we looked at adding immunotherapy, and we found an improvement when we added immunotherapy to chemotherapy. So what do I mean by immunotherapy? And again, I'm sure this group is very well aware. To a large degree, as of today, and I'm going to talk about other immunotherapies, but today, to a large degree, what immunotherapy is meant as what are called as anti-PD-1 or anti-PD-L1 checkpoint blockers. So what does that really mean? What it means is that when you have cancer, our immune system, represented here by T cell, has the ability to, the patient's T cells or the immune system has the ability to recognize the cancer and attack it. However, the cancer manages to fool the immune system, the T cells, into thinking that it is normal tissue. And our T cells and our immune system will not attack normal tissue or normal cells. And one of the important ways, both non-small cell lung cancer and small cell lung cancer do that is by activating something on the T cells or immune cells called PD-1 through a substance present on the cancer cells called PDL1. So when PDL1 on the cancer cells binds to PD1 on the immune cell or T cells, it sends a signal to the immune cell, hey, I'm a good guy, don't attack me. And so the tumor hijacks, in a way, the normal protective system within our body that allows the immune system to only attack infections and cancers and protect normal tissue. It uses that mechanism to fool the immune system into thinking, hey, I'm normal tissue, don't attack me. And so the drugs like pembrolizumab or Keytruda or atezolizumab and Tecentriq, what they are doing is they're blocking this PDL1 on the cancer cell, binding to PD1 on the immune cell. And when that is blocked, the immune cell or the T cell or the immune system of the patient can now recognize the cancer as cancer and attack it. And that results in death of the cancer. And I hope I was not too technical and this was clear. And so this sort of a anti-PD1, PD-L1 drug, atezolizumab is an anti-PD-L1 drug, was combined with chemotherapy. And we saw that the outcomes are better. The survival is better in patients. Now, when you look at the average improvement in survival, it is only about 2 months. That's the only improvement. By the way, we also saw this with durvalumab, another drug, which is an anti-PD-L1, and it showed almost identical findings as was seen in this trial, Empower 133, where atezolizumab was evaluated, as seen in Caspian-3, that looked at durvalumab. They are two very similar drugs, and both provided very, very similar benefit. But when you look at the average improvement, it's only about 2 months. But what is important to note with immunotherapy is that, yes, it benefits many patients, but in most patients, the benefit is modest. However, the promise of immunotherapy is that there's a proportion of patients, and this is true about both non-small cell and small cell lung cancer. There's a proportion of patients, a minority population, that derives this sustained benefit. And what I would like you to do is focus on the left lower sort of bar graphs that are shown. And as you can see, about 1 in 10 patients are alive at 5 years in patients who got chemotherapy and immunotherapy. Now, that is not a big percentage. However, almost no patients who received only chemotherapy to begin with survived 5 years if they had extensive stage or stage 4 small cell lung cancer. So yes, we see benefit when we add chemotherapy to chemotherapy rather in most patients. However, the promise of immunotherapy, both in small cell and non-small cell lung cancer, is that there are a minority of patients that derive sustained benefit. And we almost don't see any evidence of cancer years after them being diagnosed with either small cell lung cancer and non-small cell lung cancer. And a lot of research now is ongoing to try and see how can we provide similar benefit to patients who are not deriving the same benefit, that extended sustained benefit from the current immunotherapy drugs. And therefore, there is an interest in looking at newer immunotherapy drugs. So this was what I just showed in advanced stage small cell lung cancer. So what about the role of immunotherapy in patients who had more earlier stages of lung cancer, where we tend to do chemotherapy and radiation as our treatment, and that has been the historic treatment for many years. So what was done in this Adriatic trial was that patients who had received chemotherapy and radiation for limited stage small cell lung cancer, where the cancer was limited to the lungs and may have spread to the lymph nodes, after completion of chemotherapy and radiation, they were randomized to either durvalumab, the immunotherapy drug, or placebo. And what this showed is that there was improvement in survival, not just progression-free survival, but also overall survival. And I would contend that the benefit with immunotherapy in these limited stage patients, where the immunotherapy was given after, not with chemotherapy, as was done in patients with extensive stage disease or stage 4 small cell lung cancer, when it was given after chemotherapy and radiation, I think the benefit was even more pronounced in these earlier stages of small cell lung cancer patients than what was observed in stage 4 lung cancer. And so, on an average, the survival was improved by by almost 2 years, which is quite substantial. What is interesting is um, in the Adriatic trial, immunotherapy was done after chemotherapy and radiation. In this trial, the NRG trial, the immunotherapy was given with chemotherapy and radiation. So the patients got chemotherapy and radiation, which is the standard of care, but half of the patients got along with it immunotherapy. And what is interesting is we did not see a benefit in those patients. So there's something about doing immunotherapy with chemotherapy and radiation that doesn't appear to show benefit. Whereas if you gave the immunotherapy after chemotherapy and radiation, we see a benefit. And what is interesting is that we found the same findings in non-small cell lung cancer. So in non-small cell lung cancer, if you gave immunotherapy with chemotherapy and radiation, we don't appear to see a benefit. But if you gave immunotherapy after chemotherapy and radiation, you do see a survival advantage. The exact reasons, there are things that are speculated upon why this may be true, but we don't know the exact reason. And so I just wanted to mention both in non-small cell lung cancer and small cell lung cancer, generally we want to do immunotherapy after chemotherapy and radiation, but not during radiation. So what do we do if patients with advanced stage disease get chemotherapy and immunotherapy and subsequently they have progression? There are many different types of chemotherapy that can be utilized, but the most common chemotherapy that we use is a chemotherapy called lurbinectedin. Now, this is a chemotherapy we don't use in non-small cell lung cancer. So this is something that we use in small cell lung cancer almost exclusively. There are other drugs that can be used subsequent to lurbinectedin that we also use in non-small cell lung cancer. But this is where now the excitement is. We have now newer forms of drugs, both immunotherapy drugs and other sorts of drugs that have shown a lot of promise in small cell lung cancer. And what is interesting is that this class of drugs called BiTEs, these are bispecific T cell engagers. And what does that mean? So these are drugs, and I would like to focus on the middle figure here. These are drugs that have two heads, if I may. One head, the blue head of this drug binds to something called a CD3 on the immune cell, and the red head binds to something called as DLL3 that is almost exclusively present on small cell lung cancer. And what this drug is doing is it binds to the small cell lung cancer cell by attaching to the DLL3 present on the small cell lung cancer, and simultaneously binds to an immune cell and basically brings an immune cell very close to the cancer cell. And when the immune cell comes close to the cancer cell, the immune cell gets triggered and attacks the cancer and kills the cancer. So simply put, what it is doing is it is bringing the immune cell closer to the cancer cell and allowing the immune cell to better recognize the cancer cell and anchor onto it and kill it. And what is interesting is these type of drugs called BiTEs or bispecific T cell engagers have been primarily up till now used in lymphomas and myelomas. So small cell lung cancer is the first what we call solid tumor where this drug has been approved now after clinical trials demonstrated that this drug has benefit. And again, if you look at the benefit, it does work in a good proportion of patients. But when you look at this survival curve, you see that there's a proportion of patients somewhere in the range of about 30% that have this sustained benefit. More than a year and a half after starting the drug, their cancer remains controlled. We don't know who are those patients, and there's a lot of research going on to try and identify who are those patients who are deriving those sustained benefit from this drug. I also want to tell you that this immunotherapy, this BiTE drug, was developed by targeting this substance called DLL3 in small cell lung cancers. There are other such targets on not only small cell lung cancer, but non-small cell lung cancer, other cancers that could be utilized similarly to develop other such BiTEs or bispecific T cell engagers to do the same thing that this drug called tarlatamab does in small cell lung cancer. So this is an expanding field and could show a benefit in both small cell lung cancer and non-small cell lung cancer. This drug right now is FDA approved in small cell lung cancer after chemotherapy and immunotherapy, but they are also currently conducting trials to see what the value of this drug would be if we gave it along with chemotherapy and immunotherapy right from the beginning. So there's a great deal of excitement about this. Now, this drug does have toxicities. And these toxicities are somewhat different than the toxicities seen with chemotherapy or the other immunotherapy drugs that we use. And one important thing to remember is something called as a cytokine release syndrome. And I'm going to do my best to explain what that means is what happens is when this drug, the blue head, binds to the immune cells or the T cells, it really turns on those immune cells right away. And those immune cells go to work right away. They release a lot of these chemicals. Their goal is to release chemicals to use those chemicals to kill the cancer. But those chemicals also get released, or cytokines also get released into the general system. And that's why it's called cytokine release syndrome. It's characterized by fevers, by blood pressure dropping, by kidney failure. Now, it sounds very dramatic, and it is, but because of that, and it tends to happen with the first dose. So that is why we tend to admit the patients when we are giving this drug for the first about 24 to 48 hours. In almost all the patients, we can get them through that. And interestingly, with the subsequent doses, we don't see that. And there is a step-up dosing where we give a small dose to begin with, control this cytokine release syndrome, and then increase the dose of the drug. And another class of drugs that has generated excitement in small cell lung cancer, but also in non-small cell lung cancer, is what we call antibody drug conjugates. So what we have recognized is that there are different substances present on cancer cells that we normally don't see on normal cells. And could those substances be utilized to develop antibodies against those substances, but then use those antibodies as a way to deliver chemotherapy selectively? So what you see here is an antibody. It has the blue thing is a linker. So think of a tow truck. So the antibody is the tow truck. The yellow kind of star-like structure is the chemotherapy, and that is the towed car. And the linker, the blue thing, is the chain that is connecting the car to the tow truck. And what basically is happening is the antibody is given IV, and then that circulates. But when it reaches the cancer, the antibody binds to a substance that is almost exclusively present on the cancer. And once it binds, this drug complex gets into the cancer cell, and it is inside the cancer cell that the chemotherapy is released. As you can see, those yellow star-like structures are released into the cancer cell, and then the chemotherapy acts with the idea that the chemotherapy acts exclusively only into the cancer. And not only that, once this cancer cell is killed, that chemotherapy is released, and that can then go into the next cancer cell and attack that as well. And so this is in the end chemotherapy, but instead of just giving chemotherapy intravenously, what you're doing is binding the chemotherapy or linking the chemotherapy to an antibody that binds exclusively to a substance that is almost exclusively present on the cancer cell and not present on normal cell. And that allows selective delivery of the chemotherapy to the cancer. One such drug that is being evaluated in small cell lung cancer is called ifinatamab deruxtecan. And as you can see, this is the antibody. This sort of pinkish circle is the chemotherapy that is linked to this antibody. And this antibody binds to a substance called B7H3 that is present almost exclusively on small cell lung cancer. And this drug has shown activity, promising activity, and this is also now being evaluated in the frontline setting. So, what about targeted therapy, which I mentioned is not something that we are still using in small cell lung cancer? It is being exclusively used in non-small cell lung cancer. So, one of the major differences in between non-small cell lung cancer and small cell lung cancer is that in non-small cell lung cancer, in some non-small cell lung cancer patients, we can identify the main gene mutation that is driving the cancer. Whereas in small cell lung cancer, there's not a single dominant gene mutation that is driving the cancer. There are multiple gene mutations that together are driving the cancer. So in non-small cell lung cancer, in some of the patients, if we identify a gene mutation that is the main driver of the cancer, we can give a drug that blocks the product of that gene mutation, and then that can shrink the cancer. But in small cell lung cancer, because it is a cancer of many gene mutations simultaneously occurring, you can't give a drug that blocks a single gene mutation. It would be too much to give multiple drugs blocking the products of all the genes that are relevant for the cancer for its ability to grow and spread. And therefore, as of now, we don't have a targeted treatment, though there continues to be research in identifying targeted treatments for small cell lung cancer. I wanted to finish up by talking about early detection because, as I mentioned, in many lung cancer patients, the cancer is diagnosed. By the time it is diagnosed, it is either stage 3 or stage 4. And I just want to say that there is a way to identify cancer early, and that is through lung cancer screening. And what has been shown is that in individuals rather, who are between the ages of 50 and 80, have smoked a pack a day for 20 years or equivalent of that, a CT scan, which is a low dose CT scan, it is a scan done without IV contrast, it takes about 2 minutes, has shown to not only detect lung cancer early, but reduce the risk of dying from lung cancer. And the reason I wanted to mention it, most likely many of you are already diagnosed with lung cancer or are relatives of friends of patients who have been diagnosed with lung cancer. But I do want to make you aware, because if you know anybody who meets these criteria, please encourage them to talk to their doctor about lung cancer screening. I want to say that only about 15 to 20% of individuals who are eligible for lung cancer screening are undergoing lung cancer screening currently in the United States. I also want to say that right now, lung cancer screening is applicable to individuals who have a certain amount of smoking history. But we know lung cancer occurs in never smokers and in individuals who have hardly smoked. Right now, we don't have any defined screening tool for those individuals to detect lung cancer early. There are a lot of new things coming along, including possibly blood test to screen for not only lung cancer but other cancers. It is still very early and it's still under investigation. I wanted to finish up by talking about two things. One is clinical trials. I want to tell you that everything that I talk to you about, I can talk about because there were patients like you who years ago enrolled on different clinical trials, and therefore we could test these treatments and find out they're beneficial, and we could get them FDA approved. And if it were not for clinical trials, we couldn't get new drugs approved. But there are advantages for even patients who enroll on clinical trials. One is they are testing new treatments. And I can tell you that the success rate with new treatments, though still low, is far better than what it was 10, 15 years ago. Please understand that when you're participating in a clinical trial, it has gone through such an extensive review process, both at the federal level but also at the local level, that in a sense you're getting opinion from multiple different experts beyond the doctor or the provider who is taking care of you. At the present time, there are almost no studies that are placebo or sugar pill studies. Almost no. I did show you a placebo controlled trial, but they are a very small percentage of trials. If you join a clinical trial, you can leave the trial at any time and continue to get standard of care treatment. Um, uh, so, what I want to say is, think of trials. Doesn't mean it is for every patient, but do seek out trials if and at least listen to them. You can decide afterwards to say this is not for me and go with standard of care treatment. Somebody right before I talked to brought up a very important point. Ask for a palliative care consult. In the past, palliative care was associated with just hospice care. However, as patients are doing better, as they are living longer, it has become extremely critical. It was always critical, but it has become even more critical now, that we are not just focusing on the cancer and the treatment of the cancer, but we are focused on the patient's physical ailments, psychological ailments, their nutrition, their interactions with their family members and friends. And so, what has evolved, particularly in lung cancer treatment, and both for non-small cell and small cell, that the oncologist manages the cancer but partners with the palliative care team to address the different symptoms. And I can tell you that it provides a lot more holistic care to the patient than it can be done by the oncologist alone. So, I wanted to finish up with the patient that I talked about back in 2021. So this lady had extensive stage small cell lung cancer. Her lung cancer had spread to the pleura, of course, nowhere else. She started on chemotherapy and immunotherapy. She had a wonderful response. About 6 months later, she developed brain metastases. We were able to do SRS to her brain mets. About 2 years later, so that was in 2020. In 2022, she developed a recurrence in the left lung that initially we treated with reintroduction of chemotherapy and immunotherapy, and then subsequently radiated that area. And now she's 6 years after her original diagnosis. In September, actually, it will be 6 years. And as you can see, her scan looks normal. Those masses that were seen in the left side of the chest have completely resolved. And I really believe that this is an example of immunotherapy providing benefit. I don't believe that in a patient who had recurrence in the brain um, 5 years ago, 10 years ago, with small cell lung cancer, would have been alive for 6 years after diagnosis. And this is the reason why we are all so excited. Initially, the excitement was in non-small cell lung cancer, but we are getting better even at managing small cell lung cancer, and a lot of new things coming along.